going to talk a little bit about drug therapies for skin and soft tissue infections. I'll start with purulent, so that would be like carbuncles, furuncles, and abscesses. And the first treatment for that would be to surgically incise and debride it. And that's where you can end for a mild purulent infection. But if you have a moderate or severe, then you would want to supplement with an antimicrobial. So for a moderate purulent infection, you can treat empirically with TMP SMX or doxycycline. And those are active against MRSA, so that's where you try empirically. And then if you culture it and find out that it is sensitive, then you can use dicloxacillin or cephalexin. For severe purulent infections, you would treat empirically with vancomycin, daptomycin, linezolid, telavancin, or ceftaroline, which is a 5th generation cephalosporin. And again, those are mostly MRSA active, which you would treat with empirically. And then you can always downgrade if you find out later that it's sensitive, and then you could change to naxilin, cefazolin, or clindamycin. One note here is that daptomycin and telavancin are contraindicated in children. So instead of daptomycin and telavancin, you can use clindamycin in children, and that would be used like if the hospital has a low resistance to clindamycin. So now we'll switch over to the non-purulent infections, and that includes like necrotizing infections, cellulitis, and erysipelas. So for a mild infection, you would treat orally with penicillin VK, because that's a penicillin that has a good bioavailability because of the potassium. So either the penicillin VK, cephalosporins, dicloxacillin, or clindamycin for oral treatment of these mild non-purulent infections. And then if you have a moderate infection, you're going to want to treat intravenously. And you would treat with penicillin, ceftriaxone, cefazolin, or clindamycin. Keeping in mind that most of these infections are all caused by Staph aureus or strep. So you want to think of all the medications that are active against those bacteria. Then if you have a severe infection, like a severe necrotizing fasciitis, that's an emergent surgical treatment for that. So that would be what you would treat with first, and you empirically treat with vancomycin plus piperacillin or tazobactam, and that would cover like your MRSA or your Pseudomonas. And then once you are able to further identify what the actual organism is, you can further specify your treatment to that. And the treatment is usually a combination therapy, because these severe infections are usually have high incidence of resistance and very hard to treat. So now we'll go into more specific treatments for different infections of skin and soft tissue. So some medications that are active against MRSA are kind of unique medications, so there's not like a high cross sensitization for them. Vancomycin, linezolid, clindamycin, daptomycin, ceftaroline, doxycycline, minocycline, or trimethoprim sulfamethoxycillin, or TMP SMX. And those are all MRSA active medications. I'm going to talk a little bit about bites. So when you think of bites from animals or humans, there are specific bacteria that are most likely based off the bacteria that are present in the mouth. So for animals, you'd think of like Pasteurella multicida, and to treat for that, you'd use cefuroximine or cefoxetine, which are 2nd generation cephalosporins, or ciprofloxacin and levofloxacin, which are fluoroquinolones, or doxycycline. To treat an aerobe infection, you could use SMX or TMP or TMP SMX or trimethoprim sulfamethoxazone. Lots of different ways to say that. And then for an anaerobic infection, you'd use metronidazole, clindamycin, moxifloxacin, or doxycycline. Just a little note here, clindamycin is a 30S inhibitor because that's something that is in our objectives to know from this lecture. So 30S inhibitor for animal bites is clindamycin. And something I like to remember for all bites, animal bites and human bites alike, doxycycline seems to be kind of the common factor of the go-to treatment for all of these. So now I'm going to talk a little bit about human bites, and you can't see it on the screen, I don't think. But what I think of is Echinella, or I say Echinella. If you watch that video, how I remember all the little tidbits about Echinella. So to treat Echinella, Staphylococci, and other anaerobes, which are what you would think of most common for human bites, you treat with doxycycline, kind of the go-to for bites, like I was saying. And then for any other infections, not including MRSA, because they don't have action against MRSA, you can use amoxicillin clavulinate or augmentin, and ampicillin, sulbactam, or carbapenems, and those are not MRSA active. That's for human bites. Another couple just specific treatments that we're supposed to know. For Clostridium species, you could use clindamycin plus penicillin, and your dosage would be 600 to 900 milligrams by IV for 8 hours, or every 8 hours. For Aeromonas hydrophylla, you'd use doxycycline plus ciprofloxacin, or you can use ceftriaxone, and you would treat with a dosage of 100 or 500 milligrams IV every 12 hours, or you could do 1 to 2 grams IV every 24 hours. And so that is the drug treatment algorithm for skin and soft tissue infections.